Zhou, who's the Chief of Vascular Surgery at University of Arizona in Tucson. And she's going to talk about transfemoral carotid stenting. How will this play out with NCD approval? Go ahead, Wei. Thank you.
Thank you, Dr. Lumsden. So my topic is a little out of my comfort level. However, this is nice, what Dr. Kasuraji will talk about. It was a nice segue to what I'm going to talk about today. So this is a national coverage analysis memo. It was published October 11th, 2023, a day after my birthday. Basically says, expand transfemoral stenting coverage to standard surgical risk patients. And here's, that's including both symptomatic patients over 50% stenosis or asymptomatic patients over 70% stenosis. The memo has emphasized on using carotid ultrasound as a standard first-line evaluation for carotid stenosis, and also including as necessary CT scan and MRI. The memo also says the physician must present options to the patients. That's including CEA, TCAR, and best medical therapy. And patient must know what's a risk for each one, and everyone needs to know the guidelines. In addition, the memo mentioned the institution must establish standards for treatment for the transfemoral stenting procedure and must monitor the outcomes. So I'm not really a policy person. For me, it was really hard to figure out exactly what that means. So I went back to the notes about 20 years ago when transcarotid stenting just started. Look at this is a special communication come from three specialties: vascular medicine, vascular surgery, and interventional society. Look at what their training paradigm is, what is required. So they're actually pretty well written. And then first of all, they look at cognitive requirement for physician to perform carotid stenting procedures. One need to decide what kind of symptom does this patient have. Is it really from the carotid, or from cardiac, or from other sources? Is it from AV malformation or intracranial bleeds cause the symptoms? And whether to operate on the patient, and how to operate the patient. It is atherosclerosis or fibromyalgia, which is very different from carotid atherosclerotic disease, how you offer treatment. Also, when now to operate. And does the patient really have anterior circulation symptoms, or is it atypical from something else, or posterior circulation symptoms? So this document also talk about identify high-risk patients, know the angiographic anatomy, know the arch anatomy, and different arch classifications, and consider alternatives. Even back in 20 years ago, they're asking for surgeons to know the different options. Now here is the basic requirement: 30 cerebral angiogram or 25 carotid stenting procedure, half of which should be performed by primary operators. Surgeon need to have angiographic skills, or intervention need to have angiographic skills, which is, I think, 20 years later, probably everyone has. But everyone needs to familiar with anatomy. That's not including just carotid anatomy, but intracranial anatomy, your arch anatomy, and then know the circle Willis. When does the posterior community, the anterior posterior communicating arteries? And lastly, one need to recognize complications, and those is frequently being ignored. But this is 20 years ago that we asked our physicians to understand carotid disease, understand what's potential complication, follow carotid intervention. So this is a paper by Dr. Chris White, probably one of the paper who push the transfemoral stenting towards approval, CMS approval. And then you can see the trend line towards over time, the carotid stenting does have a better outcome. That happens for carotid CEA as well as medical therapy. In patients on lipid lower agent, their risk for carotid events for ipsilateral stroke was 1.3% per year. For those with CEA, it's only 0.7% per year. So all the technology is getting better. So what I want everyone to see, and we really want to propose, we really need to look beyond the clinical outcomes. We need to look at procedure-related microembolizations, understand them. Those can be detected by TCD or DWI. Those white dot was Dr. Kasiraj mentioned about. Those are dying cells. So that's abnormal diffusion of water between intracellular and extracellular matrix in the dying cells. So when we look at embolic volume, this is a study we did over the last probably 10 years. Follow CEA, and this is look at not only just the size, not just the number of emboli, but the size of emboli, the volume of emboli. CEA has a much lower embolic volume compared to carotid stenting patients. Now, that might change with newer technology, with the newer approaches. This is true, this is real. So we really need to comparable to medical therapy group and to CEA group, the transfemoral carotid stenting and TCAR need to have a comparable microembolic rate and volume. So even with some why is that, right? Even with some of the not very sensitive measures, such as mini-mental status exam and the MoCA score, there's multiple studies show the significant correlation between silent brain infarcts and cognitive function, which is important in our society. We also did lots of studies, look at episodic memory. We see a significant correlation. We also see the volume of emboli will have significant impact on their cognitive function over time. So the next step is to look at the risk factors. This is a study we look at this about a few years ago, look at the risk factor for microembolization. Basically, it says patient has a shorter lesion, a bulkier lesion, calcified lesion, have much higher risk factor, have higher risk for microembolization. Now, we also look at volume, embolic volume, what's the risk factor for larger volume lesions. From patient standpoint, older age and obesity predict larger embolic volume. Patients on antiplatelet therapy tend to have a smaller volume for patients with undergo transfemoral carotid stenting procedures. So in summary, there's multiple options for patients with carotid disease. Technology is evolving, and eventually maybe all the technology have a similar comparable outcome. But the goal of training is really provide the best outcome for the patients. And we need to look beyond the traditional outcome measures, and importantly, to identify high-risk patients. Okay.
Thank you.
Thank you very much.
Thank you.
And then,